speaking of that, I was looking at an email the other day where it was a CPESN person who was saying, hey, I wish some of the stuff we were doing were harder so it mattered.
Well, I've certainly learned over 25 years of being a licensed pharmacist that for the most part of all the healthcare professions, we're probably the most sadists.
Yeah. So Pioneer has driven this down to just check boxes and a list of what we have to do, and that's not really clinical. I wish we had to. I wish it was harder.
Oh, Jeff, yes, thank you. We should do a whole Click and Clack podcast just on that, right? Yeah. That drives me crazy, frankly. And these are folks that are friends of yours and I's, and people that are CPESN luminaries and whatever else. Now, I understand where they're coming from, which is, an honest day's pay for an honest day's work. But, every time I hear, well, yeah, but that's just a MedSync, and that's not real care planning. MedSync is a service.
It absolutely is.
MedSync takes work.
Yeah.
MedSync provides real value. It does raise adherence rates. It does keep people out of the hospital. Just because you might have gotten good at MedSync doesn't mean that it has less value.
Is giving a shot clinical? Is looking in somebody's ear clinical to see what's blocked in their ear?
Right.
Do I need to write? Do I need to type that I use such and such a device to peer into patient's ear at a 45-degree angle and then move?
Right.
No, I check the box. So
we are natural sadists as pharmacists, self-flatulation, or what's the term? Or I want to keep punishing myself, right? We're prone to that, and I think part of that comes with we've had, and look, I come from a family of academicians as well, but we've come from a more academic energy around practice transformation rather than a business sustainability energy around practice transformation. And what's really, really cool is we've started work with the schools of pharmacy and the colleges of pharmacy is I think we're starting to more appropriately blend those two things together, which is, hey, here's what care looks like. Here's what you really actually need to do if we're really going to be doing care management, if we're really going to be doing titrations and therapy, et cetera, et cetera. But at the same time, administering a flu shot is a real service that provides incredible value. Counseling them on that, doing MedSync, doing some of the stuff that some pharmacists think is basic, still provides a lot of value. Look, the core of primary care is basic stuff, but they also do hard stuff. But the core of primary care physicians' work is basic primary care, and basic pharmacy care is valuable. It should be documented. It should be within workflow, and it should be paid for, right?